My name's Julie McCrossin, and I, as the intro said at the beginning, I am a person who has a passionate interest in this topic because of my own direct healthcare experience. And just before I tell you about that, I just want to really note, Elizabeth, that the strength of that comment, have the courage to measure outcomes. And one of the things in our panel discussion, when we have questions from the audience, I'd love to ask you about is, why it does require courage, because I really agree that it does. And I sometimes feel that compassionate multidisciplinary teams are almost frightened to truly know the results and what we're feeling as patients and family, because they're not sure that they can address the unmet need, because they're working so hard to deliver the basic curative care or prolongation of life care. And so to have a sense of the extent of unmet need may be overwhelming. And I would suggest that is particularly so in this period of COVID and the pressures that are going to be on our international health systems, probably for several years to come as we grapple with the pandemic. But look, ladies and gentlemen, in my time here, and a picture has come up, I think, on the screen of myself under a mask in a radiation bunker, and I'll explain what I want to say about that in a moment. But my intention in this presentation is to advocate for real-time provision of a voice to patients. So our voice in real time, so that you can, in partnership with us, achieve real-time improvements in care, while at the same time collecting large data sets that can enable you to do structural improvement in care over time. And I also am really interested in an active role for patients. As someone who was treated 8 years ago for stage 4 oropharyngeal cancer, so that's cancer in my tonsils, tongue and throat, caused by the human papillomavirus, HPV. So that's a sexually transmitted virus that doesn't just cause cervical cancer, it causes anal cancer, oral cancer, vulval cancer. And there is currently an epidemic of HPV-related oropharyngeal cancer occurring. I understand because, and I'm in my late 60s, the baby boomers got busy with oral sex in the 60s and 70s, and this predominantly long-term, slow-developing cancer is now becoming much more common. But I'm not going to focus specifically on head and neck cancer, but rather on an aspect of the treatment that caused me grave difficulties. And it's one of 3 examples, positive examples I want to share with you, where a real-time voice is given to patients with the opportunity to improve the care for that patient in real time, as well as collecting a large data set and giving us an active role, my 4 key messages, which I will didactically repeat. So what you see before you, and I've got a picture because I think if you haven't seen it, you can't really believe it. But I was treated successfully, 33 consecutive days of radiation, 20 minutes alone in the bunker. And the mask is to keep you rigidly still. It's a personalized, rigid mask, so that the radiation will hit the cancerous tumours and not hit the extremely vulnerable organs and, all the healthy tissue that you don't want hit, particularly the brain or the spinal cord when you're dealing with that upper area. Of course, with conventional radiation therapy, there is some damage going in and out. I had sort of circles of loss of hair out the back because the radiation machine would move around my head and fire it to me. But look, the main point I want to make is that for a whole series of practical reasons that I won't take time to tell you, by chance, I didn't get pre-treatment education. I didn't know what the bunker, that's the room where you have this radiation delivered on a LINAC, a linear accelerator. That thing above my head is firing radiation beams, and it rotated so it could come at different angles. So I had never seen a bunker. I'd had the mask made, but perhaps with the shock of a stage 4 diagnosis, my cognitive capacity was diminished. As you would know, this is a common experience for people with a serious health diagnosis. I just didn't understand that I was going to be lying flat on a bench and that rigid mask would be clicked tightly down on my head so that I couldn't speak like that because it was so tight. And the reason it's so tight is that during the 33 days of treatment, because, as Elizabeth referred to, radiation affects the swallowing and speaking capacity of head and neck cancer patients, I lost over 20 kilograms in that treatment period and the week or two after. So they make it terribly tight at the beginning so that when you lose that weight, because most people do, you can still use the same mask. Anyway, the main point is, it was clicked down and I immediately panicked. I said, take it off. They did, but I remembered all the people outside. I remembered that the machine kept breaking down and therefore there was a delayed queue, that many people urgently needed treatment other than me. And I'd been told that if I had the surgery that was available at that time, which would have been through the side to take out the cancers, I would have lost speech and swallowing for life. So I felt I just had to suck it up. And I did. The difficulty was that it was 20 minutes of red in the face, water pouring off me, and heart palpitations of the most extreme nature. And the point of this story is that happened for 4 days in a row. And I did ask for help. And I still don't fully understand why the radiation therapists in my very caring team didn't refer me to someone who could help me psychologically for those 4 days. And I finally, after the 4 days, I went to a nurse and said, I can't go in there anymore. And she got me mild sedation, music, and a psychologist. So that's my story in a nutshell. I promised myself if I survived that I would try in partnership with caring clinicians to prevent this happening to somebody else. And I have become a kind of radiation bunker guru. I have travelled all over the world to look at radiation bunkers and to see how other people prepare people like me for treatment. And I'd now like to request our technical team to play an interview with a woman called Dr Bina Brown, and she'll explain who she is. And she's got a solution that I think is consistent with what Elizabeth is advocating for. Please show the video. Well, it's such a pleasure to introduce Dr Bina Brown, Principal Allied Health Research Fellow in Cancer Care and an advanced speech pathologist at Princess Alexandra Hospital in Brisbane, in Queensland. Well, at least you were until a few moments ago. You've now gone to the Menzies School of Health Research. But how long have you worked prior to that at Princess Alexandra in Brisbane?
I started working here as a new graduate speech pathologist in 2002, so it's been 18 years that I've been here at PA before I moved to Menzies.
And how much time have you spent with patients receiving radiation?
I started in radiation oncology working down here in 2005, so it's been 15 years of my life, which I've enjoyed every second, and during that time I also did my PhD in radiation oncology.
And one thing you've been doing is called Health My Way. What is that, its purpose, and how does it work?
Yeah, My Health My Way is an electronic web-based patient-reported outcome tool. So in cancer research over the last couple of decades, there's been a real push to hear the patient voice and hear the family voice during their cancer treatment, because it adds so much value to the care that we provide. So My Health My Way is a way for patients and their families to connect with their healthcare team. So patients enter their data of how they're experiencing treatment onto an app during treatment, and that directly connects with their healthcare team. So referrals are made to different members of the team based on the information they enter.
If you can describe the waiting area where people are waiting to have their radiation treatment, we've often got family members with us. Where is this capacity to enter information about yourself, and 3 or 4 examples of the sort of questions you're answering?
So there's 2 different ways that people can enter their information. One is on a stand-up podium, so it looks kind of like an ATM machine in our waiting area. So patients and their families can come up to the screen. It's a touch screen. They can enter their data that way in the waiting room of our radiation oncology department. Or alternatively, people get sent out a personalised SMS message to their own device So they can also complete their data in the comfort of their own home or when they're out and about. It doesn't have to be in the department.
So give me a sense of what sort of things I'm telling you as a patient, whether I'm doing it on the pedestal in the waiting room or on my phone at home.
So you're telling us information about how you're physically experiencing treatment, so any physical side effects you have related to pain or nausea or a whole range of different physical things that are specific to your cancer type. You're also telling us how you're managing at home practically, as well as how you're managing emotionally and how you're getting on with your family members and relationships with other people, as well as your experience of distress and things that might be contributing to that distress.
As you know, Bina, I have an interest in distress because I found the experience of radiation treatment with the mask tough. So if I was filling in the podium in your waiting room while I was waiting to go in and I said that, you know, while I was in the mask I was sweating and going red and the heart was going fast, what would happen? What would happen after I reported that?
So there is a specific question that relates to mask anxiety on our tool. So people can tell us about their general anxiety, but separate to that, people can explain their experience of mask anxiety. And if your mask anxiety is at a level that is severe enough, then a clinical alert, as soon as you press enter on your data, a clinical alert gets sent directly to our occupational therapist and radiation therapists, and they're aware then from the moment that you enter that data that's what you're experiencing. So automatically a referral would be sent to those health professionals to support you during your treatment.
This is all about how to improve the patient and family experience of radiation. How does this Health My Way system improve the experience for the patient but also the family?
So we have also validated the tool for carers and family members. So there's a separate tool that carers can complete alongside the patient. And it also allows then, if the patient is doing really fine and the carer or the family member is having a hard time supporting their family member, then the health professionals can direct their care to the family or the carer in that instance.
So have you done research on this? Do you have any data on what patients and family are telling you or the impact, the evidence that this is worth doing?
Absolutely. So we've looked at all of the data that's come out through the My Health My Way tool, and it was previously called Screen It. And we have over 7,000 entry points of people who are reporting their data to us during treatment, and that's resulted in patients receiving the right care at the right time when it suits them and by the right professional. It's resulted in 25% less outpatient appointments needed for patients. So if patients are doing fine and they don't need to see their healthcare team at that time, then we cancel those unnecessary appointments. So it allows people to spend more time doing the things that they want to do rather than being at the hospital.
And Bina, just finally, where did this idea come from? I mean, as a patient, I'm thrilled by it. Where did this idea come from? Because it takes the hit and miss out of whether someone notices you're in trouble.
Absolutely. So I think we conceptualised the idea in 2013, and we had a feeling that we were probably over-servicing some aspects of cancer care. So we were seeing people too much and they didn't need to see us that often. But we were under-servicing other aspects like the psychosocial elements, so the emotional response to having treatment, the distress, the anxiety. So we wanted to find a way that we could understand exactly what was going on for patients and provide the care for those specific things.
Bina Brown, who I would marry, except she's happily married and so am I. Can I just say that she mentioned she got the idea was born in 2013, and of course I was treated in 2013. The other thing about 2013 was that there was no source other than the Cancer Council booklet Cancer Council for our friend Elizabeth, you may already know, is a series of councils across Australia, plus a national one that provide all manner of information for cancer patients. It's really our primary source other than our team, and most hospitals have all that information up there. But in that booklet, because after I recovered, I went back because I thought, why didn't I see the mask in that? Why didn't I understand what I was in for? And I discovered there was no heading with the mask in it. There was one reference to the mask in one sentence embedded in one paragraph, and there were no pictures. And I do believe that unless you've seen that, you cannot comprehend it. It's so alien. And to be honest with you, there's a lot of alien stuff in healthcare. I was in an episode of Doctor Who when I had head and neck cancer. Subsequently to 2013, clinicians and patients have got together, multidisciplinary clinicians, and made an organisation with a brilliant website called Head and Neck Cancer Australia. And I just want to promote it by putting my little ambassador's badge near, and I want to commend them. And I am involved in making all manner of videos so that no one has to go through what I went through again, and they're fantastic at distributing them all over the place. I just want to commend them too at Princess Alexandra in Brisbane for having that pedestal in the waiting room, so I could have come out, I could have entered my concern, and I could have had real-time help. Because you need to know that I cried profoundly after my first treatment in that mask, and I haven't cried since. It's 8 years. I'm so grateful to be alive. I love survival, but I am deeply traumatized, and it could have been prevented. Not everybody will have the motivation skills to get that marvelous thing in the waiting room. But look here, here's a model Linac made by a little boy in Adelaide who's brilliant, and he's got a little patient, and they've 3D printed a little mask. And I have been advocating for 8 years that one of these little Lego thing could be in every waiting room, because my partner and my friends who took me to treatment didn't know what was happening to me. How could I explain? How could they support me? Radiation is an outpatient treatment. I have given these to cancer centres, and they cost a bit of money. It's actually a highly skilled thing created by a boy wonder in the world of Lego. And even when I give them to multidisciplinary teams, they get very excited, but they don't make them and they don't put them on display. And yet this would be a cheap thing. And I look forward in the panel to understand from Elizabeth, why is change so hard in health? Could I have my next positive example? Which is an image from an app, just one image from an app created by the Peter MacCallum Cancer Centre. This is in trial at the moment. I was alerted to this by a cancer survivor called Shona Edwards. She's 25. She had proton therapy, which is a kind of radiation therapy not yet available in Australia, but there is a scheme. If there's evidence it will be really beneficial, they send you and your family to have it overseas. She, as a young woman in her early 20s, had a difficult tumour on the base of her spine, and she was sent to Prague to have proton therapy. And there they had an app called My Therapy app, which enabled her to enter real-time data on her pain. I'll just use that as an example. There were many elements. And it generated graphs. So she was able to take that graph generated on the history of her pain fluctuations, and she experienced extreme disability and pain during her treatment. And she could take that data in a graphical form, accurate, to her clinical team, and that helped in pain management. And I know, as you would know, just how busy clinicians are. And if you can give them more than just a quick verbal summary, if you've got something concrete and impressive in terms of reporting your immediate treatment needs, you're much more likely to get help. Now, this screen is from one from Peter Mac. It's called Regenerate. You can enter exercise and getting active, diet and nutrition, emotional health and well-being, fatigue, relationships, intimacy, sex and fertility. Frankly, I'm glad they do it for the young. This is designed for young people. Don't forget the over 60s would like intimacy too, but that's another story. Study, school and work. She entered data in relation to pain and fatigue, and it generated she says you can do this with the Peter Mac one as well. And I just want to commend Peter Mac because, again, a caring group of skilled clinicians have really listened to patients and thought, what tool can we give patients so they can report to us? And again, it's got those key elements I'm advocating for. It's got real-time voice to patients. It's got real-time possibility for an improvement in care. And it generates large data sets. This app, when it becomes utilised, it's still in the full-on development phase, although it is available on an app site, will generate large-scale data, as Dr Bina Brown's one did, and it gives an active role for patients, which, as you can probably imagine, when your life's on the line or physical disability, my friend Shona, who showed me this, is using a wheelchair and a walking stick at 25, although is developing her walking capacity, and she hopes to have children at a later stage. But, you know, you don't want to passively, you know, be a cork on the ocean of the health system. You want to help yourself and you want to help others. So my final example, and this is a picture, if I could have my next image. This is my mother, my late mother, only 2 years gone at the age of 94. And she's in a rehabilitation hospital after having a fall and cracking her pelvis. And I use this image because, one, my mother just had the most amazing resilience. She's what you would call in your systems a frequent flyer. You want to use value-based healthcare to reduce my mother's admissions because you could save a mozza if you could, because she was an expensive unit. And I have attended many accident emergencies with my mother, so I know what an accident emergency admission is like for an elderly patient. And Mum began to have some cognitive difficulties, and they're designed to make you confused. But what I want to applaud is something I've heard about, which is the New South Wales Osteoarthritis Chronic Care Program Service. So I'm sitting in my office. I know I've got 6 minutes. I'll just tell you, the other day, I fell off the chair where I am onto a hard surface. If there's any OTs there, you'll be horrified. I've got a wheeled chair without a rug or a mechanism of making it still. And I fell on the ground and I heard myself think, oh my goodness, Julie, you've had a fall. Notice I didn't say I've fallen over. And I knew that I'd learnt the language of the geriatric and I was becoming one. I use the old terminology, but you know what I mean. And I have many friends, sadly, who've had knee replacements, and they're, as I understand it, terribly expensive for you guys. And they're, let's be honest, not always effective. And they can cause mobility and pain issues of considerable magnitude. And I recently visited a friend who had one, and you know, I visited her in hospital 5 or 6 times, and she was getting brilliant care, but she was having a lot of difficulties. I've been visiting her now about 6 weeks after her treatment, and she still has difficulties. Now, what I like about that New South Wales initiative is it's access to a multidisciplinary team, and it offers the possibility of preventing surgery. Now, Elizabeth mentioned a similar example from your world in the United States. The New South Wales one, I was sorry to see you have to be on a waiting list for surgery before you qualify. And I understand that. That's all about the targeting of scarce resources. And so I guess I'll close by saying I will do my best to put together my own multidisciplinary team to prevent falling and lose the weight and do the exercise to avoid the knee replacement that is on my horizon. But if we can use this approach to care to target resources where they are really needed and save some money, we might be able to offer the glorious healing power of access to multidisciplinary teams before you're on the waiting list for surgery. You know what I'm saying, guys. You know, primary prevention is always best. Elizabeth, I can see your face. Do you think I think I've said enough, and I think we should go to our discussion. But just if you are working in cancer, just Google my name, juliemccrossin.com is my website. And if you're prepared to make one of these and put it in your waiting room, I will donate it so that patients remember what they're about to see in the bunker, and family understand that it's a slightly spooky experience. Thank you very much.